Carl, thank you very much for joining me in this conversation. It's a pleasure to have you here. We have known each other now for 35 years, I think, and your work has made an enormous difference to my thinking and to many other people's thinking. So our task today is just to reflect upon that journey and to remind people who don't know, or inform people who don't know, and remind those who do of the journey and where we've come from. My first encounter with your work was through the book that you and Carol Trevett and Angela Deal published in 1988, called Enabling and Empowering Families. And on the strength of that book, we first invited you to Australia in 1990. And that began our journey. I'm interested in where the ideas for family-centered practice came from. What were the origins of the work that you put together?
Well, there were multiple sources. At the time I became director of the Family Infant and Preschool Program, I think it was 1981 or 1980, I became involved in a number of initiatives which at the time seemed unrelated. Is the Family Resource Coalition in Chicago, which had developed a set of family support principles, and the Association for the Care of Children's Health in Washington, D.C., that had developed in collaboration with the Surgeon General at the time, is a set of family-centered principles. There was a third set that was developed out of Syracuse University that involved a set of family support principles specifically for families of children and adults with disabilities. Those things came to my attention at the same time that I was grappling with trying to facilitate changes in the way in which the Family Infant and Preschool Program staff work with families. At the time I became director, they were using professionally driven, highly prescriptive practices with the families, and complained to me all the time that the families never followed through on anything they did. And I tried to get them to engage in conversations about the reasons why. Is one thing I did that turned out to be somewhat controversial, but is about a year into the attempted transition, I invited as many families as wanted to come to meet with me and to share their thoughts about the way in which we work with families and children. Is, if I remember correctly, I think about 40 families showed up out of about 80 families that were being served at the time. I made it real clear to them that everything they said to me was personal, would not be shared with the staff, except in general comments. And that's when the parents' comments sort of confirmed what my suspicions were, that what the staff were asking the families to do either didn't fit with the ways in which the families thought they needed help, or that the help that they were being offered became more of a burden than a source of support to the families. And so I think it was in 1982 or 83 is when Angela Deal was hired to work at the Family Infant and Preschool Program. And she and I had numerous conversations about the so-called problems that the staff thought the families had, and what these family-centered principles and family support principles would suggest the way in which you should work with families. And we developed a number of different strategies, which quite frankly didn't work very well. And that's when we invited families to help develop a set of family support principles that would be applicable just to our program and organization. And there was about, maybe a dozen parents over the course of about 6 to 8 months, where we met once a month to look at all the principles from the Family Resource Coalition in Chicago, Family Support Principles in Syracuse, New York, and the Family Center Principles in Washington, D.C., to talk about which of the principles made most sense to them in working with families. Once we developed a set of principles, we basically did a Delphi study of all the families that the program was serving at the time. And we used the results of the Delphi to identify a core set of principles that the families generally agreed were the way in which they wanted to work with the staff. And that was sort of the foundation for how we thought about is work with families, conversations. That's when things like supports and resources got identified as important, including what we did as an organization, is that the families thought they needed from other persons and organizations. Is the families didn't explicitly describe this, but what they were describing basically were help giving practices that would help the families feel more capable of providing supports and resources to their children with disabilities. But the one thing that came out of those conversations and the Delphi study was the families basically told us in our initial groups is that they were tired of being blamed for things that didn't go well. And that was the foundation for beginning to develop a family strengths approach to working with families, which we never thought we would ever do. It was never on the agenda. And then we started to look at the work that other people were doing in terms of family strengths. And that work was the foundation for the family functioning style scale, which was an attempt to identify is characteristics that other people thought were important in terms of focusing on family strengths and building on family capacity. And all those things sort of converged as part of writing, enabling, empowering families.
So that family strengths angle wasn't in the ideas that you've been looking at.
What was it?
The family strengths emphasis. From what you're saying, that came from the parents rather than from the other ideas and sets of principles that you've been looking at.
Well, the principles that we started with were a combination of ones that came from families, the Family Resource Coalition, and the ones that came from Syracuse University, and the ones that came out of Washington, D.C., that were really were developed more by professionals, but in response to what families were telling them, they wanted professionals to work with their children with special health care needs.
So you had, the impetus was a combination of sets of ideas that were emerging at the time and feedback from parents, direct feedback.
Yeah.
So what were the key features of the key principles that you identified through that process?
Well, there were a number of them that are kind of interrelated. One was focusing on things that work well in families and trying to find strategies to build on those to either support families' own confidence and competence, but also in terms of the children. That was one focus. The other one was active family decision making with input from professionals. I mean, one of the things that we learned early on was that most families just were unfamiliar with the resources that were available to their children and families. And so one important role that the staff played was to describe the resources that were available, not only from our own program, but from other programs and organizations and other sources of support, including family members and non-professional organizations. The other practice that tended to be important was the parents' active role in obtaining resources and supports with the support of staff, not the staff mobilizing the resources for the family. For the families to do is the strategy that I suggested. I'm not sure it always worked as well as I would have liked, but is I always said to the staff, identify the 4 or 5 things that you need to do to get the resources that the families need, and ask the families which of the things they feel confident doing themselves and which things they would like to do together with the staff. And for the most part, most staff felt confident with that approach. Some families had a difficult time making the transition from being told what to do to being able to be active participants in obtaining the resources and supports.
Yes, families have to learn how to do that because they tend to come with the assumption that they don't know what they need, what can be done, and they think that the experts are the people to do the job. So it is a shift for parents as much as for practitioners. So you identified a set of principles around basing services on family priorities and basing it on family strengths and building family capacity and so on. You have gone on to test those hypotheses or those practices in various ways. Do they stand up? Has there been any challenge to these, or has the evidence continued to support these as important elements of best practice?
Well, early on, there were a number of individual studies that we conducted just to test basic assumptions about what we thought was going on with families. And one of them study I did with Hope Leet, who was a social worker who was doing an internship at our program. And the basic principle, her basic assumption was that unmet family needs was a factor associated with their likelihood of securing resources and supports. And so we did a number of small scale studies. But Carol Trivett's involvement was she became involved in our program in 1982 as a master's student, and she did her master's thesis on relationship between different types of support and family functioning, mostly well-being and parents' beliefs about their children's capabilities. The results from that thesis together with some instruments I basically told her she had to include to be able to do her thesis, was the foundation for demonstrating the relationship between is types of social support and positive family functioning, family well-being, parent well-being, is child well-being. And while I was director of the Family Infant Preschool program for 12 years, we did a whole series of individual studies. After I left the program is when I got interested in whether or not those results could be replicated by looking at other studies that other people had conducted. And that was the foundation for all of the meta-analyses that we've done, which I think there's like 60 or 70 meta-analyses that we did, looking at each component of the model is social support, family resources, family strengths, help giving practice or family-centered practices. And the results from all of those research reviews show that the relationships are either directly or indirectly related to the outcomes that we looked at, child, parent, and family outcomes. But the key of everything was parents' personal beliefs about their capability of producing changes in their children's lives, which we initially called empowerment, then self-efficacy, and then eventually looked at it in terms of competence beliefs and confidence beliefs, which is where most of the more recent meta-analyses included those separate belief measures.
So self-belief. So the job is partly to help parents believe in their own capacity to make a difference. And if they don't have that belief, then they're less likely to be able to make the changes that are needed.
Well, we initially used Bandura's theory, where behavioral actions that result in expected consequences are likely to reinforce one's beliefs that they have the capabilities of accomplishing things that people intend or think are important. And it's like anything else. Sometimes you have to start with small steps. And so I'll give you a concrete example. Is when parents brought their children in for developmental assessments, is oftentimes it would be the first time the parent were ever told that their child had an identified disability, and oftentimes they would immediately say, well, I don't know anything about that, and I'm scared to do. And one of the things we would ask them is there anything that would be immediately helpful to you? And almost every time they would say, I just need more information about my child's condition. And what we did right on the spot is provided them information about their child's condition in a format that was written for parents to help them understand. And so we say, you know, take this home with you, is take a look at it. And after, when the staff come out to make a visit in a week or so, is we can discuss is what your thoughts are about your child's condition at that time. I know it sounds silly, but it's one of those things that parents often said as a first step, it was one of the most helpful things that ever happened, because we as professionals assume that parents know more about their child's condition than the parents often know themselves. And so I would always encourage the staff to figure out what they know, what they don't know, and what they would like to know, and to focus in on what they would like to know in order for them to be motivated enough to engage in actions related to what they want to know, or want to do. And
But, but
it
you
usually took
started,
small steps like that.
but the starting point for many parents is, I don't know, I don't have information, and I can't do anything. I don't know what I need to do. So how the service and how practitioners relate to parents shapes what the parents think they can do. So basically the professional, the practitioner, has to believe in the parent's capacity to do things, and the parent has to then believe in their capacity. So I think you said something at the recent, you did a keynote at the Lisbon conference where you were talking about family strengths, and you said every family has capabilities and strengths, and there are no exceptions. Every family's got it. Our job is to find it. Our job is to believe in the family's capacity to change as much as they need to believe in their capacity to make difference.
Is many staff were able to make the transition from being able to recognize family capabilities of doing interventions that professionals were trained to do with sufficient guidance and support. There were unfortunately more than a few staff who would just say to me, I didn't go to school for 4 years for me not to be able to do the interventions I was trained to do. And I would explain to them, well, that's okay, but who's going to do those interventions when you're not around, which is most of the time with the families. And that was the foundation for developing the principle that all families have existing capabilities as well as the capacity to become more competent, and there are no exceptions. And you have a responsibility as a professional to figure out what those are.
Mm-hmm.
And that's partly where this notion came from. Okay, there's 5 things we have to do. Which things do you feel okay doing as a parent, and which things do you want to do together? That was the sort of the foundation for being able to operationalize that principle.
Yeah.
And most staff eventually were able to do it with sufficient support from their supervisors and from other staff who became able to do it. And so it wasn't unusual early on in the process is for a staff member who has a difficulty making the transition to go on home visits with a staff member who had already made the transition to being able to figure out what the families were capable of doing and how to build on capacity. And oftentimes those staff would tell me, well, after I saw so-and-so do it, now I have a better understanding of what I need to do.
Yeah. So the transition that you took the staff through was one from them being experts and designing and delivering the intervention without consideration of family preferences or needs or strengths. And that's an absolutely major transition. It really is a paradigm shift in how you operate. So, and early childhood and family-centered practice has always proven somewhat problematic in delivery. It's hard to deliver consistently. So, how how did you manage that transition within your centre?
The family support principles that we had developed in collaboration with the families, those became standards against which myself and all of the supervisory staff interacted with all of the direct service staff. And so, for example, when I interacted with direct service staff who were explaining to me what their plans were with the family, I would try to pick out one or two of the principles and ask the question, help me understand how that's consistent with this principle that families should be making decisions about what's important for their child and family. And so it was never questioning the staff's practices. It was always using the principles as a standard against which we asked the staff to judge their own practices. And I can't remember how many supervisory staff I had, but I met with the supervisory staff once a week to discuss the issues that the supervisors had in their work with their own staff, to begin to discuss what we could do to help the staff make the transition to practices that were consistent with the family support principles. And I know it sounds rather straightforward, but that's basically what we did, is to help the staff make the transition. How is that consistent with this principle? And initially staff would say, well, there's some families that I work with where that principle doesn't apply. And then you'd have to say, okay, let's assume that it applies to all families that you work with. Help me understand why you think it doesn't apply to this family. And then we would work through that process. And it's a time-consuming process, and it requires consistent attention for staff not to fall back into only using professionally centered practices. I mean, that was one of the lessons we learned, is that it wasn't like staff became family-centered and then you could stop paying attention to it. It was just constant. It was all the time.
So family-centered practice really requires ongoing attention and mindfulness to what you're doing and thinking about it. Otherwise, you get, I think we had what I've heard referred to as professional drift. You just drift back into doing what's easiest for you and what you've been trained to do. So part of the work on family-centered practice and subsequent work involved identifying help-giving practices that were most effective. What were the key practices that you identified?
Well, it's actually a funny story. We never thought that family-centered practices and effective help-giving practices would be the same thing. One day I was sitting at my desk getting ready to do 2 different presentations, and I had the family-centered practices. These were back when we were doing overheads.
Yes.
I had the overheads of the family-centered practices on one side of my desk, and I had a list of what people said were effective help-giving practices on the other side of my desk. And all of a sudden, I looked at both of them and I said, these look like the same things. And as it turns out, people in the help-giving practices literature call some of the practices different things than what the people in the family-centered practices field were calling family-centered practices or principles. And Um, that that was the foundation of trying to integrate the two together. Um, is when we first started with the help giving practices work, is Carol Trivet and I did it as an extensive coverage of the literature as we possibly could do to identify what people said were effective help giving practice, with the caveat that that the helpee would get better at accomplishing what the help giver was trying to do.
Yeah.
And so there's a pediatrician, he's retired now, there's a pediatrician here in Asheville that I did some work with. And one day we were having a conversation and he was telling me that the problem with pediatrics is that we make all the families dependent on us, and then we complain that they always coming to us to ask for help. And so he actually wrote a book for pediatricians talking about help giving practices and empowerment as the foundation for how to work with families in a way that the families don't become dependent on the pediatricians for all the advice. And that was the focus of the initial help giving research. And when we developed the help giving practices scale, which we used in a number of studies to demonstrate that the practice is informed decision making, collaborative work, is facilitating parents' abilities to obtain needed resources with minimal support or without any support from professionals. That's where all that stuff evolved from. And eventually is when I was asked to do a chapter on help giving practices, and we pulled together all the literature from different professional fields, is one of the conclusions we came to is that most help giving practices are ineffective in terms of helping people become capable of doing things themselves.
Yeah. So you've got the help giving side of it, which is relational work, but it doesn't necessarily build people's capabilities. So your emphasis on, well, you use the term participatory practices.
One of the things that came out of our own research and other research is that unless, let me back up, being nice to people isn't sufficient for building people's capacity to be able to do things for themselves or their children. And that's where the idea of participatory came from. And so I don't know whether you know this or not, but I was on Ian Dempsey's dissertation committee when he developed the enabling practices scale. And then he came and did some time with me in North Carolina, where we used his enabling practices scales with families in North Carolina to figure out whether or not the pattern of results in terms of what we initially called enabling practices which we later called participatory practices, were similar. And what we found was that both for Australian families and American families, the same pattern emerged from the data, is practitioners who used enabling or participatory practices, there were more positive benefits than just using relational practices.
So you can make people feel better and enjoy and value the support that you provide. But if you don't also build their capacity to do stuff for themselves and with their children, then nothing much changes. The child child doesn't benefit. Okay, you eventually all of this work led to or evolved into your applied family systems model. How does that relate to or incorporate family-centered practice?
Well, what we initially called just help giving practices, we eventually turned that into just family-centered help giving practices, and describe family-centered help giving as a particular type of help giving style that was responsive to families' concerns and priorities, but also is promoted active family members' involvement in either providing their children different types of experiences or obtaining supports and resources that they needed.
You have gone on to test every element of the applied family systems model, as you referred to before, which I think is, I don't know anyone else who's done that, Carl. You know, this is unique. You come up with a theory and then you say, okay, you know, does that hold? Is it possible to demonstrate that the different elements of it relate to one another in the way that the theory predicts? So I think it's powerful. What's the best place for people to find your stuff? And given that you've published so much, then the question is how to choose. So where's the best place and what's the most useful resources? Are you able to answer that?
Well, as you probably know, is that as I got interested in developing performance checklists as a foundation for helping staff have a more concrete example of what different practices look like, is the monograph, the freely available monograph that is on the Puckett Institute homepage, describes the foundation for all of those checklists, which we actually developed, is initially for the Early Childhood Technical Assistance Center in Chapel Hill. And the Puckett Institute website includes other examples of resources that we developed specifically for practitioners and parents to implement different types of practices. So for example, I can't remember. I think it's the Center for Early Literacy Learning, where we develop what we call reminders for parents. Remember, when you're doing this, remember to do these things, and which parents told us that was the most helpful for them when they were first learning to use a practice. That after they sort of mastered it, they just stopped using the reminders. And so the Puckett Institute website is probably the main source of information for our attempt to operationalize some of these practices.
Right. Okay, we will make sure that we put the link up when we broadcast this conversation. Your presentations in Lisbon are now on ResearchGate, are they not?
Right.
Yeah. So we will put up the link to those as well.
If you want copies of them, I converted the PowerPoints to PDFs, and I can send them to you if you'd like.
I think they're available. I think they're on ResearchGate as PDFs, aren't they?
Yes, yeah, they are.
Yeah, okay. So I think people can download them from there. I think that's fine. What else are you working on, Carl? And how long are you going to keep doing it?
You ready for this one?
I'm not sure. Go on.
Because I got involved in working with some people from Portugal, Ukraine, and Ohio on a study that they did, was actually a survey of Ukrainian parents of children with disabilities receiving early intervention during the initial invasion from Russia. And we actually just, the paper was just published. It's on ResearchGate. But as part of that is I got interested in, okay, the invasion was a traumatic experience. What's the relationship between other traumatic experiences and negative effects on parents' psychological well-being? Well, as part of that is we're in the process of finishing a meta-analysis of the well-being of women throughout the world following the Russian invasion of Ukraine to determine what it was about the invasion that caused negative effects to parents' well-being. And actually all the data has been analyzed, and I'm finishing up the discussion section. It includes lots of studies from Australia and New Zealand, and other countries in the South Pacific. Is in the literature, people make these statements about what negatively affects people's well-being without understanding what the context is for making the statements. And so we tried to divide European women into subgroups, and then it's North America, Oceania, and the South Pacific, and Latin America and the Caribbean, to determine whether or not there's any differences in the effects of context on women's psychological well-being, which has turned out to be a massive undertaking.
It absolutely is a massive undertaking. Well, I'm glad to hear you're not idle. You've got something to work on. Carl's pleasure, as always, talking to you and hearing about the research. Your approach, your systematic approach to exploring and testing ideas, I think, is exemplary. I think you've made of all the people I know, you've made the most substantive contribution to the early childhood intervention field over the years. I want to thank you for that personally and on behalf of everyone else. We hope that our new best practice framework incorporates a lot of what we've learned from you, and we hope to keep on learning from that. So thank you very much. Thank you for spending the time with us, and it'll be and good luck. We will be very interested in the findings once you've managed to sort out the problems of the world. We'll be very interested to see how that goes.
All right, Tim, thanks.
Thank you.
All right, talk to you later.
Before we launch into and sort of see whether there are any questions that people have, can I make some of the key points that come out of that discussion? We covered quite a lot of ground. I'm familiar with all of this material, but many other people might not be. So the key points that I think that are being established here from Carl's stuff is, first of all, these are principles of family-centered practice and the applied family systems model. First of all, there's the support that we provide through early childhood intervention is going to be based on the needs and priorities that the families identify, not those that we identify, and Carl talked about the way in which the program that he was involved with originally did too much of the business of deciding for the families what the focus should be. Another point, a key point in Watt and Carl's work is that parents are helped to meet as many of their own needs through their own resources. This is a powerful message because, as we said a number of times in that discussion, parents tend to feel that the professionals know how to do everything better than they do and should be the people who get them the resources, and professionals can collude with that and do it for them. His argument and his evidence is that we need to be able to help parents to meet as many of their needs through their own resources. Another point is this one about strengths and the fact that everyone has strengths and our job is to find them. This is not necessarily easy. We tend to look for the things that are not going well in families or in the interactions with between parents and children. Our job is to reframe that and look for the things that are going well and highlight those and bring those to parents' attention. Then there's the help-giving practices, the relational and participatory, to use Carl's terms. So the relational is how we respond to and build trust with parents. And the participatory one is how we help them, coach them, help them develop capabilities. Participatory meaning they have to participate in what we do if things are to get better for the family and the child. Then there's the issue of parental beliefs, which I think is really interesting. So the parent has to believe in their child and they have to believe in their own capacity to do things that will benefit the child. At the same time, the professional has to believe in the capacity of the parent to learn to be able to do this and in the methodology that has been chosen. So the set of reinforcing beliefs there that are profoundly important to our effectiveness. Other points I would make is that family-centered practice is multifactorial. You can see it's not a single thing. It's got a series of elements to it. So we have it as a principle in our best practice framework, but it's a multifaceted principle that includes a number of different elements, particularly the relationship between practitioners and parents is a partnership. This is fundamental. Each brings their own expertise and we work together. The parents have the ultimate call on what to focus on and what methods to use, but they're doing that with the benefit of the knowledge and expertise that the professional brings. There's also the question of focusing on the needs of the family as a whole and the caregivers in their own right, not just on those of the child. That's a tremendously important principle. And then the question of the resource needs of families. Carl referred to some of the work they've done on this space, that if we do not pay attention to the circumstances in which families are living, the resources that they can draw on, material basics as well as social support, then we will miss out on understanding some of the things that shape their capacity to do what they and we would wish. Okay, I will stop there in my summary of some of the key features of Carl's work and open it up for questions. Kerry or Paula, is there anything in the chat that we should be responding to?
Tim,
Yep.
there was just one comment really that it would be fantastic if there was more success sharing in the Australian context of how we use this approach and make it work, given some of the current challenges that we experience, the commercial nature of the therapy or transactional nature of the therapy in the NDIS context, and also workforce issues. So, you know, the amount of time that it requires and the benefit of having experienced team members who can lead this approach. So kind of more of a comment and a request for that. So I don't know if you've got a comment to make.
Certainly something, the business of sharing success stories and ways in which this has worked, I think that's a job for Pracy. We can think about ways in which we can provide a place where people can record those. There are resources on the, as part of the best practice framework, podcasts and videos that expand upon some of these ideas. With regard to the current environment and whether or not it promotes this way of working, I think as that comment notes, it doesn't. It does the opposite. And it's difficult for practitioners to work in a way that's consistent with the best practice framework or with family-centred practice when we are working under these kinds of conditions. So the job now is in the redesign that's going on of the NDIS and in the development of the Thriving Kids initiative, that we push the line that the redesign has to ensure that the way in which services are funded and structured promotes best practice rather than undermines it. And that's a big challenge, but it's a very interesting one. How do you design a system that by itself encourages best practice? We're working on that.
Thanks, Tim. There was a comment about the role from Helen about the integral role that key workers might be playing in this approach. Did you want to comment on that?
Well, a key worker is the frontline person, obviously, so therefore their use of relational and participatory practices is going to be central. They're working with families to think about the needs of the family as a whole is going to be central. They're focusing on family strengths and all of the key aspects of family-centred practice. They need to be embodying in the way that they work with families, and they need to facilitate family access to the expertise of other people as well. But really, their relationship and the way that they work in a family-centred way with families is vital to the success of what we're doing.
Carl, Tim, I can see that Susan Jackson has her hand up.
Susan.
I was just thinking of questioning the working with families. I think is vital, and I'm, agreeing. But the question that was coming in my head was, when families are really struggling, like we're always putting the best interests of the child first, and then that could be in conflict with, I'm wondering, is that in conflict of where the families are at? So, we have a mandated notification responsibility. And then there's the information sharing guidelines. I'm working in a preschool that has an integrated preschool program in it, but we have lots of children in our mainstream program, as most places do. And I'm just thinking of sometimes the interests of the parents, or when parents are separated, and obviously looking for their strengths is vital. But when that is in conflict of what will be the best for the child's safety or outcomes.
Yeah. There are ways of working in family-centred practice, using family-centred practice principles in those circumstances. So that's a particular way. Yes, there is an obligation upon us to make notifications in the cases where we think that the child is definitely at risk. That always but that kind of decision does need and can be made in conjunction with families, and using these essential principles. So if we have been able to develop a relationship with families that is based on trust and based on partnership, and that is not by any means guaranteed, and not necessarily an easy thing to do in some circumstances, but if we can, then our capacity to help families negotiate those kinds of situations and to think about the best interests of the child and so on is greatly enhanced, not totally resolved, but certainly enhanced. But I mean, it's a great question. It is an ongoing issue, and I think if PRACE is to develop, we're going to be able to develop some further resources around the best practice framework, then that's an area we might focus on. How do you work in a family-centred way in families that are divided or where parents appear to be not acting in the child's best interest? Thank you for that.
Can I just add something that sometimes, like, we do pride ourselves on forming those close connections, particularly in the IPP program. We often have children from foster families, which I'm thinking of foster families in the same way that I'd be thinking of other families for the purpose of what I'm saying. But where I think some of that sort of communication changes when it looks like a parent has suddenly gone downhill and is not in a place where she's able to think clearly, or he's not able to think clearly about best things for herself or her child. Sometimes those moments occur.
And can be very challenging. I think that I think there are models for how you deal with those kinds of situations. We can find some of that within the child protection literature on ways of maintaining a relationship with parents while you are dealing with difficult subjects. Again, I think PRACE should take that on board as an area that we can develop some further resources on. Thank you. Any other hands up?
There's one here. I hope you can have a go at answering this one. It's a reflection on how family-centred practices, especially supporting families and children in the home and other settings, are a central part of best practice. And a comment about how we can bring government early intervention services out of hospitals and clinics into the natural environments. And how do we look at creating a change on a national level?
Thank you. That's a nice, easy one.
I thought you'd like that one.
I rather liked Carl's practical approach when he was talking to his staff about making the transition from being the expert to working in this new way. And he would use that technique he described of saying, well, here's the principle. Can you help me understand how that principle applies in this case if you're doing it in this way? How is that? Now, we've got principles in the best practice framework which go beyond family-centred practice, but they include working in natural environments, and because that's the place where the child is going to do their learning. That's where they spend most of their time, and that's where the parents need to learn. Parents and other caregivers can learn how to provide children with environments that are going to promote their capabilities, and so on. So we can use the principles, therefore, in that kind of way when we're approaching the whole Thriving Kids design. In what way does this proposal meet the these principles or conflict with them? So I think that's, that will touch upon things like the proposal that you've got doesn't include funding for travel. And we've got a working in natural environments best practice principle. So help us understand how the system you've designed is going to enable this to happen. So it's possible to use the framework as a way of scrutinising the change. I think at the moment, my reading of this very messy scene that we're in, where things are moving very fast and a whole lot of parallel and not necessarily overlapping changes are occurring, is that there is an appetite for thinking about this. There is a welcoming of the principles without understanding necessarily what the line I've just pushed, that we should be using. We can use the principles and the framework itself as a way of challenging or testing proposals to ensure that the design actually does facilitate best practice. Let's hope we can actually get that across.
Thanks, Michelle, for bringing up the question. There was another reflection earlier up in the that I thought was quite interesting as well, and that was looking at, and you kind of touched on this a little bit, where do we go in terms of and how do we support the shaping of expectations of families about what these practices are. But I also think shaping the expectation of referrers was also mentioned in that comment.
Yep. Well, you saw some of Carl's take on this, which was that when he was quoting the paediatrician who was talking about people becoming too dependent on. So if parents are not given any opportunity to think about goals and outcomes that they want and what changes that they want, then they will fall into the expectation, the default expectation, that what they need for their child is as much expert help working with the child as they can get. So one of the dilemmas that we've had with the NDIS, of course, is that people are getting large packages that they don't necessarily need and that aren't necessarily good for them, and that primarily, or in many cases, focus on the provision of centre-based, clinic-based direct therapy from the therapist. The parents do need the help of therapists. The child doesn't need therapy. What the child needs is access to the expertise of speech therapists, OTs and speechies, psychologists and the like, and special educators, in order to be able to learn what they can do to be able to provide the child with the information they need with the environment they need throughout the course of the day. So how do we get that across for parents is a really interesting challenge. And I think it has to do with the pathway that they follow. The pathway through from having concerns and then having contact with professionals and professionals referring them on to, say, the potential NDIS candidates, that kind of thing. That's a pathway. Now, at the moment, we're trying to redesign that pathway. The NDIA is trying to redesign the pathway through to the NDIS, and Thriving Kids needs to have a pathway as well that leads parents through. That pathway needs to be able to work with parents to help them think about goals and outcomes and what they need right now, rather than services. Outcomes and goals need to come before services. This is the key thing. So we need a system that does that. Now, in the best practice framework, we have a decision-making guide which does this. It takes you through the steps of getting to know the family and so on, and then finding out what their priorities are and all of that strength-based stuff, what their needs are, and so on. This is before you make any decisions about services. So the issue of services is determined by the goals that the families have, the strengths, the resources that they have to tackle some of their needs already, and what additional resources they need that they can't do on their own. So it's it puts it a different way around. And so if you start from helping families in these sorts of ways, work through their goals and so on, and what they need, then you will get away from some of this tendency of thinking that what I need is every bit of therapy that I can get for my child. So that's the aim, that's the effect that we hope that the decision-making guide will have. So there are some programs around. The ones that I know about include Plumtree's model in New South Wales of Now and Next, which works with, has families facilitators working with parents with no professionals present, working on what are your short-term goals, what are your long-term goals, what can you do to achieve those. So getting a goal-focused, outcome-focused mindset right up front. The Envisage program also does that, and I'm sure there are many other examples of good practice out there where people are using that approach. But that's it. Focus on goals and outcomes before you get to the question of what service do you need and how much do you need. Again, there is a resource paper, there's an appendix to the decision-making guide on this very question: how much service do you need, and how often should you have it, which again reinforces these points.
I think that's all we have, Tim. There's no other hands up.
Yeah, okay. Carl spoke about a set of principles that he had developed with the families in the program that he ran in Asheville, North Carolina. Those can be found in the keynote address that he gave at the Lisbon conference. So if you have a look at that's to be found on the ResearchGate link that's in the chat. And I really liked that that process? How do you find out why your program is having a problem? You get the parents together and you say, you can tell me anything you like, and we will work with you to identify what the issues are. We should be doing that as a matter of course. That is, we should be taking the principles of family-centered practice and treating them at the next level up, as it were, running an entire centre service based upon family-centered practice. And if we, going beyond that, I would say we should have a service system that is based upon these principles. And it'd be nice to have a government that operated on them as well. Just a modest ambition.